Nairobi.
All right, joining us live in the studios to talk about more about telemedicine, we have the Murang'a County Governor, Irungu Kang'ata, is in the house. Right next to him is Dr. Joseph Murad. He's the CEO of Bayan 8.
And sitting next to him is Steve Smith. He's the Chief Operating Officer, HealthX Africa. And next to him is the CEO, Roy Borg. Good to have the four of you in the studio this evening.
Governor, real quick, you saw the package there.
Yes.
Telemedicine. There are a lot of people out there who have no clue what that is. Explain to us.
Okay, telemedicine is the delivery of healthcare through digital means. So, for instance, a doctor is here, but the patient may be, let's say, in Turkana or Murang'a. So you are communicating through some digital device, whether, let's say, a laptop, a phone, and you are giving Medicare through that device. Basically, it means that. But of course, there are several things that you need to have in place. That includes the hardware, that is computers, laptops. Number two, the software. Number three, you need staff who are trained in that area. And most importantly, also internet and the networking. So once you have that infrastructure, then you can render telemedicine.
So is that where we have Bayan 8 and HealthX Africa coming in? Dr. Murad?
Yeah, thank you. And by the way, you can call me Joseph. That's more than enough. That's really where the telemedicine services come in to now support and provide the services during the Murang'a pilot, which we've gotten the opportunity, of course, through the governor and the county, and enabling these remote consultations with patients.
So the pilot started on the 2nd of September, Governor?
Almost a week ago.
Yes, indeed. And the reason we did that, number one, we are targeting patients with chronic, non-communicable diseases like hypertension, arthritis, diabetes. These are patients with certain conditions which require routine checkup by doctors. So you find patient travels very far away to seek those services to a doctor. Let's say in Murang'a, villages near the forest, they have to go all the way to Murang'a town for Murang'a level 5 to see a specialist. On average, a patient uses about 1,000 Kenya shillings, plus now the consultation fee, the money for paying for the medicine. So what telemedicine does is to remove or reduce the travel cost. You don't have to go to Murang'a town to seek those services. You go to your nearest clinic, you talk to the doctor remotely, and you save your money. Secondly, when you go to Murang'a, you find a very huge queue, people wanting to see the expert. Now, this would be more scheduled, more planned. And again, therefore, once as a patient you go, you see a doctor, you go back to your normal work. And that way also, it makes the care to the patient a little bit better.
Steve Smith, real quick, the governor was talking about network availability. Do we have that capacity? Do we have the 4G or the 5G in counties like Murang'a, in counties like Makueni, as you saw in that package?
Yeah, and I think that people are thinking ahead, they're thinking of the future. As we just heard, you know, telemedicine is going to be part of healthcare to come. So, for example, in the county, we have dual power services at each of the facilities. We have the solar power, we have generators where we can't put the solar power. For the internet connectivity, we're using two different providers. We're using satellite links, we're using the normal internet type links. So we always have that redundancy. Because for telemedicine, you need to have these things in place. There's nothing worse than sitting, you know, having a consultation with your doctor and the power goes off or the internet fails. So this is rapidly growing now in all the counties, especially within Murang'a, and they've made you know, the efforts to ensure that this service can be provided.
So what does the pilot entail? Where are you starting? What are you testing out during the pilot before you roll it out fully?
So Murang'a has about 160 medical facilities. That is Level 2, they're about 120. Level 3, we are talking the health centers, they're about 25 or so. Then we have the large hospitals, there are 8 of them. So currently we're only doing telemedicine in, how many there? 38. Yeah, 38 medical facilities. So it will be about 6 months. If it works, we upscale to all the facilities. If it doesn't, we drop because it has not worked. And
you're willing to take that risk?
Yes, we have been doing that with other programs. We rarely go direct and do something because we want to see the mistake, the positive, and then we harness the positive before we actually do the final thing. A good example is like the school feeding program, where we give 42,000 ECD learners free porridge. We did a pilot, then we saw the problems, then we were able to mitigate that. The same way with other programs like the subsidy program for our milk and mango farmers. Again, we started it as a pilot. Then once we saw the problems, we were able to mitigate and upscale to the entire county.
Roy, how does HealthX Africa come in?
HealthX, we're proud to embark on this pilot. We have started this before in Nandi County, and we think there's a huge deficiency in the healthcare system in Kenya, but also when you think about Africa and sub-Saharan Africa especially, there's too few doctors. Therefore, telemedicine must be the way forward. You think about WHO says you need 1 doctor for 1,000 people. In Kenya, the average is 1 doctor to 4,000 people. But when you go across the counties, you'll find some counties with 1 doctor to 50,000, 1 doctor to 100,000. So HealthX comes in by deploying doctors sitting virtually in what you'd call a call center, and they're able to serve patients across the country. We're grateful for Murang'a County. Through the pilot, we are setting up what you call virtual clinics in, for example, Mathioya sub-county, where typically there was no doctor. So patients used to go, but there's no doctor. So now, when they go to these facilities, there's 100% availability because our doctors are 24/7 sitting in our call center in Nairobi, and doctors are able to consult. So we come in to strengthen the healthcare system. One of the biggest problems is us to think that we want to disrupt. So we are there to strengthen what is already there in Murang'a and to make it better in service delivery.
Joseph? You insist on Joseph?
I insist on Joseph, yeah. There are others who deserve that title more than me. But yeah, I mean, as Roy was saying here, and maybe to echo on the same and looking at the numbers from the World Health Organization, if you're looking at the challenges just from a global perspective and then trickling them down to Kenya, there's going to be a expected shortage of around 10 million healthcare professionals globally by 2030. And then you ask yourself, why is this the case? Well, one of the big reasons to why we're having a shortage is because, number one, the logistics. And we're talking logistics, well, you're spending time as a health professional, as a patient, going back and forth to a facility, right? That's time that could have been saved by promoting and doing consultations online. You also have the aspect of administration. There's a lot of doctors, or let's say a lot of people who are not aware that health professionals are spending almost a majority of their time on administration, documentation around the patients. So is there a way that we can also automate these things so we can spend more time on the patients? And thirdly, and this is one of the most important aspects, is how we deliver healthcare to the population. Now, for example, not everyone will be able to or need to see a doctor. Sometimes it's enough to see a nurse. Sometimes it's enough to see a clinical officer. How do you guide them to the right instance of care and make sure we use those resources appropriately? Because as you can hear, there's a limit to the human resources. So how can we digitalize, so make it more efficient? And this is now what Roy was touching about, right? There's a huge shortage of doctors in Kenya. And my last point, if you allow me, yes, there is a shortage, but there's over 2,000 unemployed doctors in Kenya right now, unemployed. So then you're thinking, well, how do we activate them? How do we make it more accessible and affordable? Again, coming back to telehealth, Bionate, HealthX is now that we can also employ and distribute these services online so more people can have access to it. And we're very grateful that the governor and Murang'a County has given us that platform.
Joseph preceded my next question, and he said there are about 2,000 unemployed doctors in Kenya. Governor, why don't you just take these doctors and deploy them throughout your health facilities?
Several factors. Number one is the cost implication. Murang'a County and most of the county, I think 100% of them, we pay our employees on and above what is provided for under the law. Public Finance Management Act provides that the salaries component of a county budget should not exceed 35%. But Murang'a, for instance, our salaries budget is 46%. And in fact, when you go now to what we call actual budget, it skyrockets to about 50-something%. So we are always being told by the Senate, by the control budget, do not employ more. In fact, we are supposed to fire people. It's only that we refused on humanitarian grounds. But we really don't have a lot of room for us to employ more. In fact, whenever we see, let's say, for instance, some agitation for a little bit of more support, then that is always some danger to the counties, because that then means you have to consider whether do you pay more and then you stop employing or even getting money to buy for medicine and other interventions. So in a way, telemedicine is important because there is that need for people to have doctors. And therefore, when you have telemedicine, it's a little bit more fairer and more objective, because now in Murang'a, for instance, we are opening so many clinics, so many dispensaries, so many hospitals. Like I think for the last 2 years or so, we have established more than 15 new medical facilities. We have to staff them. We have to buy medicine. So telemedicine will make us a little bit, our costs be more affordable and reach more people.
And just a correction, Jeff.
Go on.
Actually, I remember there was a headline and it was actually 4,000 unemployed doctors.
Why is that?
Why there are so many unemployed doctors? Well, again, you come down back to the economics of things, and as the governor has already expressed, right, there are budget limitations, of course, and what you can do and how you can hire. And the other aspect is also how do you deliver the demand to the doctors? Because right now, what is your only channel to reach these doctors? It's clinics, it's facilities, it's hospitals, it's physically attending a consultation. And again, looking at how you actually digitize the access to healthcare, now you can start enabling other channels for patients to access these doctors as well. Again, you know how it is. You're outside, you're in the rural areas, you're going to get to a facility, you're going to take 90 minutes to go and see a doctor, right? Yeah. Are you always going to do that? Probably not, right? But now, when you have a demand, when you have a need, and when you need to talk to a doctor and you can access them virtually, this is now how we can create the supply as well of services to the people who are most in need as well.
Steve Smith, this pilot program has been operating for less than a week now. What's the biggest challenge so far as COO?
Very, very exciting, the numbers. Because when we first looked at Murang'a County, they'd already made plans to look after chronic disease management patients, roughly around 33,000 in the population that they know of with chronic disease. Within 3 days, 15,000 people registered for the telehealth, telemedicine program. Wow. So for us, straight away, we knew that, we had to deal with that capacity. How could we do it? How could we move the project along? And I think both from HealthX and BioNaid, this was incredible. We'd never seen this before. So from operations side, everything was in place. We were very fortunate. The county had looked at not only the infrastructure things that we talked about, but also telemedicine on its own doesn't work. From an operations point of view, you need the team, you need all the elements. So if you imagine you go and do a teleconsultation and the doctor prescribes you a prescription, if there's no medicine to give you, then, it defeats the object of the telehealth services. The same with the lab services, the same with the referral. Within the county, His Excellency and the healthcare team work very closely to ensure that all these holistic elements and components are there So this isn't just, you know, a telemedicine by putting a screen there. You need the whole infrastructure. And Murang'a County has actually developed those things, and we are developing them, and we learn every day from the experiences from not only the patients, but also the teams, how we can do them. Like we are training the doctors, we're training staff to be able to support the telehealth and the telemedicine services.
So, Roy, you're talking about you've done this before in Nandi County?
Yes, actually, as we speak, we've served patients in 37 out of the 47 counties of Kenya. This is through a mix of technologies. There's, of course, the mobile app. There's a toll-free line, meaning you don't even need to have internet. You can have a Mulika Mwizi. So we've managed to reach patients in 37 out of the 47 counties. So it's something that actually works. It's not something that is on trial. In Murang'a, it's the model, because what the government has done through the recent enactments, it allows us to integrate into the primary care networks of a county. The government has envisioned that private players have something to add when it comes to the healthcare delivery, because there's no way, as a governor, you'll end up building so many dispensaries, so many hospitals, or hire doctors, as the governor has mentioned. So private sector has a role to play in strengthening the healthcare system. So we've done it before in a different format, but this is the first when it comes to the county model.
Here's a big question, Governor. Everyone is asking, what's it going to cost?
So for now, we are not paying anything. It's free. Yeah, it's just an MOU. We have entered into memorandum of understanding with the two entities. Because
so is it private-public? Is it a private-public partnership?
Yes, you know, for now we are not paying anything. So they want to test whether the model can work. As we also want to see whether several factors we want to study is, one, are the patients willing to pay? Number two, will it work? You see, after the 6 months, that's where now we can see whether we can have some other arrangement. And if the public really wants it to go on, that's when we can consider some form of financial discussion. But for now, it is no cost on
so the county. So there are people who still give free service?
No. There are some things they do. Number one, they pay 100 shilling. They also buy the medicine, except if you are on the county universal health care card, the one we call Kangata Care, you are getting free service in terms of the medicine, but you are paying the 100 shilling for the consultation. That money is being retained by the county facility. It doesn't go anywhere. It is retained there. It is used to defray various costs, the internet cost, and also to replenish the medicine. It's the same money they pay when they go to Murang'a Level 5 Hospital or Maragua. Remember, this is decentralization of the services that were being rendered in Murang'a, but now they are being rendered at the village dispensary level. So they are paying at the same rate, but it is being retained at the same facility to be redefrayed for various costs and other things that are being rendered at that level. And now, there are many investments that the county has done to ensure this happens. Number one, we have put in solar in every facility, so that a cost on the county. Secondly, internet. Remember, you have to ensure the internet is stable. That's quite an investment. And the other thing is also training of our staff, which is a continuous progress, and we really want to thank Murang'a County staff for the dedication that they have shown in this new idea. But of course, it is still at the infancy stage. Currently, we have about 13 medical facilities that are offering telemedicine. Our plan is to reach 38, so we still have some work to do in the next 2 weeks to plan for the 25 medical facilities which are still outstanding. But it's not just telemedicine. We think we have a long journey to make our healthcare good. We are not saying we are 100% perfect, but as Waswahili say, a long journey starts with one step. Yes.
So you were talking about a toll-free number, is it, Roy? So you go and you're saying you can do this with Mulika Mwizi. So is it a USSD code that you enter? How does it work?
So it's a subscription service, and this is away from the county model, where you dial a number and then you connect to either a GP, general practitioner, nutritionist, or psychologist.
So this is
that's
separate
the way,
from what's happening in Murang'a.
The county model is based on what you call a virtual clinic. So think of the county dispensary, then you would have a screen which the doctor behind that is sitting at our call center. But the triage aspect is done by the county nurse or employee on the ground.
So the screen can look like anything from what, a phone, a laptop?
So think of a 24-inch screen, which allows for two-way communication, because it needs to allow the doctor to hear and also the patient to speak into the device. So a big enough screen which will allow also for the doctor to do some basic diagnosis, even for basic dermatological issues, for instance. So it needs to be big enough also for the patient to feel like it's a real interaction. So that's the county model. But for example, if someone, to your question around toll-free, someone who needs to speak to a psychologist, they could call from the basement or in their car to do a voice call to speak to the psychologist for even 1 hour. They don't need a screen in that scenario. So that's where the toll-free comes in.
And, and Joseph, so far, less than a week later, do you feel like it's overloaded, the patient load? Is it, we're talking about 15,000 in less than a week. Is it a big patient overload?
From a software capacity perspective? Well, obviously it strains the system, and this is sort of what you get to test out during the pilot as well. For us, so just to kind of give some background about Bionate, so we have over 400,000 users in total in our platform right now. And this is outside, county as well. So we're used to kind of handling higher volumes, but the key, and if I may address the biggest kind of elephant in the room with telehealth, it's how do you ensure data privacy and make sure that everything that you store in these platforms are taken care of and that they're anonymous and they are also stored in the correct way. This is now where you get into the compliance of the Kenya Data Protection Act, for example. For us, who are originally an EU company from Sweden, we also comply to GDPR, which now also means that every single record that's in the system is anonymized, pseudonymized. There is no way for anyone to track or see that, hey, Jeff has been here and he had this symptom and this and this. You should never be able to track back to that kind of record. Everything should be anonymized. So from a challenge perspective and from like an overload perspective, privacy is absolutely sort of the center point to make sure we can scale this up.
But Governor, what would be your vision for this partnership?
So one, if this works well, we plan to upscale one to all 160 health facilities. That's number one. Number two, we want to plug in to other experts who are outside Murang'a, who are in Nairobi, outside the country, in places like India, in America, in Europe. It is possible now, basically, to now consult a doctor who is in America through this system. But that is a long-term, mid-term goal, not now. The other issue is to ensure availability of drugs. Yeah, I think that's very important, because what we have realized, patients, from there they see it, they can only say they are happy once they get the drug. So we must ensure drugs availability at the local level 100%. Failure to that, people will not see any form of interaction. The other one is how do we ensure the medical records is also given to the patient, because currently that medical record tends to be retained by the facility through the system. So we really need to train our patients to ensure they also get a copy of that medical record. It exists, by the way. Remember, the software that we are using was developed in collaboration with the national government. And therefore, we really need to do public education so that the wananchi can get that medical record. The other thing is to ensure other things also work. Remember, health is something that is holistic. Yeah, it has several non-health facets to it. That is, for instance, agriculture to boost income. Remember, there are some problems that are poverty-related. Also, to ensure our hospital infrastructure is also well in the entire county, and also we are also seeing some gaps. Maybe we might consider to have more staff. Thank you.
This telemedicine obviously deals with the non-communicable diseases you talked about, right? What about emergencies? If someone has an emergency, does it work?
Well, that's the point, right? Because we need to be able to deal with emergencies scenarios as well. Now, there are several things you can do to mitigate as well and take care of the patient. So number one, whenever we engage with a patient from a telehealth or consultation perspective, for example, in Murang'a County, these patients are triaged. You're looking at their blood pressure, you're looking at their temperature, etc. And if you see that in any case, any of these vital parameters are alarming, the next step is naturally not to talk to a doctor virtually. You need to get hands-on, get some help in the facility and so forth. So it's very important to be able to triage them properly and then navigate them to the right instance of care. As for the case of Bionate, so what we also have to support this, we have an entire triage built through artificial intelligence, which means that if we ever identify that parameters are off during a consultation, whatever it might be, we will give an alarm and we will send that patient to a physical consultation as well. And this is the same case, for example, if you're at home, because as HealthX, as Bionate, you have a smartphone application, you can access it in different ways, right? So what do you do when you're home and you're accessing remote consultations? Well, we have SOS button, emergency calls, and our doctors are trained to immediately recommend the patients to go to an emergency facility if we detect this. So I believe that this is something that we are thinking of on a daily basis to ensure safety.
Maybe I can mention the projections that have been done by various studies say that in the next 20 years or 10, more and more people will be seeking medical services. Why? Because our population is getting older. We are having more elder people now because life expectancy of humans generally has been on the increase. And when people get old, their main concern tends to be healthcare. So it will be impractical for all those people to come to the hospitals, otherwise the hospitals will be bursting. Yeah. So telemedicine helps now to reduce that pressure, so that the people who go to the hospital are actually the people who need what you are now referring as emergency care. So one of the role of telemedicine is to decongest the people who come to the main hospitals. Main hospitals should be referrals and for inpatient care. So let me give you a good example. Before Murang'a automated its services, our record used to show that we used to have 700 patients in Murang'a Level 5 hospital, outpatient. After we automated, records now show every day Murang'a has an average 1,500 patients. That's double the number. Now, all those people from where I see it, some of them can be treated in other facilities. So that the only people coming to Murang'a Level 5 are the one really needed expert care. So therefore, telemedicine will help us decongest Murang'a Level 5, and those actually who reach Murang'a Level 5 are the emergency, casualty, and the people really needing experts. Otherwise, if you allow things to stay as they are, you will have people who are not so sick, the very sick, all of them queuing together, and that to me will not give very good patient outcome to those who really need to see the expert in the referral hospital.
Roy, are you taking out the human element from medical care? You know, if you see the same doctor consistently, then he's able to track your progress. If this is, as you say, a call center, today I get one doctor, tomorrow I get another doctor, and I don't know who this person is, are you not taking the human element out of the practice of medicine? Is it not turning it into a factory?
Absolutely not. It's actually the opposite, because we allow our patients to book appointments. You could actually end up having the same doctor consistently. And this is very important when it comes to mental health, for example. You don't want to speak to Dr. Roy today, let down your heart and explain everything. Then tomorrow you speak to Dr. Steve. So you want to consistently maintain the same doctor. So we allow that. The technology allows you to book appointments. You can actually see the calendar of the doctor. So we've left the patient with actually a personal doctor on their phone. So it's quite the reverse, and the human touch is there, and it's very personal. Think about it at typical county hospital. You would go today, you see Dr. X, tomorrow is Dr. Y. But in this scenario, you can be able to actually ensure, even calling from home, you're speaking to Dr. Roy consistently. So it's the opposite. Yeah.
I wonder what the Kenya Medical Practitioners and Dentists Union think about all this telemedicine.
Still can say.
I think these are early days, and you have to work with all the organisations. So KPLC, for example, when I arrived 4 years ago, there were no telehealth regulations. They worked fastidiously to create a system. So now you have to register as a level 2, 3, 4, 5 facility before you can apply for telemedicine. So they're very much involved. And obviously the doctors and the professionals are also involved in creating a service that's safe for the patients, that gets the outcomes you need for the patients. And we're seeing that already. And also these will develop. You can look around the world and you can see all different healthcare systems, all different healthcare models. They all have their issues, they all have their challenges, but you can take parts of that. And what Murang'a County is doing is they're looking at all these aspects, they're bringing in the bits that make sense. But we're involving everybody. The Ministry of Health, their IT systems and their support to the county and to us as private companies has been phenomenal. And we're all developing this together. So I think, you know, if we can keep this and make words into actions, then I think this is really going to, you know, expel. Just another fact is that everybody talks about telemedicine. At the end of the day, it's the outcome for the patient. And all the statistics, and there's a lot of data that's going to be collected from this, a lot of quality data, that's all very confidential. But that leads to how you can create the systems. How many doctors are you going to need? How many clinical officers are we going to need? How many nurses are we going to need? How many facilities? All this is part of the journey for telehealth and telemedicine. And it's amazing, really, what started to happen. And this is just one example. If you bring this in the whole of Kenya, it would be phenomenal. 80% of all illnesses you can actually treat over the telephone. So you think about, you know, that, but you need to have that access. It needs to be affordable and it needs to be quality care. And that's something that telehealth and telemedicine can foster.
Governor, paint a picture for us the next 5 years, next 10 years. What's it going to be like in your county?
Well,
if you're still going to be governor.
I really don't want to really...
Come on, Governor, you can go out on a limb. Come on.
Okay, well, let me just assume the best case scenario.
Yeah.
Yeah? The best case scenario, if everything is constant, the ceteris paribus, one, we will have a situation where patients will get care at their home. Yeah, they will no longer have to come physically seeking a large proportion of their medical services in the hospitals. That will improve the number of people seeking Medicare, but also reducing the pressure on physical infrastructure of the hospitals. That's number one. Number two, we will have reached a stage where we can now get consultants from far away. People may not even have to physically go outside the country. Remember, we have something called medical tourism, where so much money goes as we take our patients to India, to UK, to seek medical services. At that time, God willing, we ought to have reached a stage where those services are now readily available here in Kenya. Thirdly, we'll be making better decision making because of the data that we'll have collected. And God willing, Murang'a will be at the forefront in that process. We should have now integrated artificial intelligence in the management of healthcare in Murang'a. Remember, for you to leave the level of artificial intelligence in Medicare, the first thing you do is to collect a lot of data. So that now you can now do what is called machine learning. And we are happy that Murang'a has been able to establish the infrastructure that creates that space for data that will make the patient care for Murang'a people better 10 years to come from now, if everything remains there. Remember, when we started, we never thought we'd be at this level, because Murang'a used to have a lot of papers. When you go to a hospital, you carry a physical card. Now people no longer carry physical card. When you go to the hospital, there are so many paperwork where the doctor is expending a lot of time filling up papers as opposed to giving the actual service. At least that now we have been able to do away with. But of course, there are so many gaps that we think in the next 10 or 5 years, we will have been able to plug those issues. And probably now we go to more advanced Medicare. Of course, we believe that journey, we cannot do it on our own. That's why we have this partnership from my friend from Sweden and my friend from UK. We are happy. Last week, we had some doctors all the way from Switzerland who are in Murang'a Hospital doing surgical services. And let me take this opportunity to thank my friend Dr. Victoria from Spain, who is domiciled in Murang'a Hospital, who has been able to mobilize those doctors to come and offer those services in Murang'a. But in the next 10 years, those doctors can now literally offer those services when they're in Switzerland or Spain, when our local doctors are in Murang'a, and particularly because of now this what we are calling telemedicine for surgery. We are about also to introduce automated radiology services. You know, radiology here we mean things like X-ray, MRI. Once you do those imaging, you need somebody, a doctor, to do that interpretation. Currently, it's a little bit manual. So once we move now to the internet-based radiology, then all the images taken in Murang'a will now be interpreted by a doctor at the comfort of his office through automation. That improves healthcare, and God willing, in the next 2-3 months, we'll have reached there. Finally, we are in the middle of discussing what we call aggregation of sample, lab sample through drone system. Again, if that works, we will be able to do more tests using the drone technology in a more objective manner. And I think that's a journey we aim to reach in the next 10 years, God willing, in Murang'a. Whether I'm in or I'm not in, as long as we establish the base and the protocols for that.
Joseph. Who owns the data at the end of this pilot? Yeah. Whether he decides to move forward or not, who will own the patient data?
Well, a very good question. Naturally, it is something that now is with the county as well as the patients themselves. Us, as you could almost call us third-party providers or services who are enabling the online access to care. Our biggest job is to make sure, again, coming back to the privacy aspect, right, that we can deliver the data to the county, because behind the online health service, you also have now another system that's called AFIA-KE, which is more of a medical record system where patient data is stored. So what you see is essentially data now going back and forth between, let's say, Bionate, HealthX, and the AFIA-KE system, right, and us to enable that communication between those.
Bottom line, the fact that you're solar-based, does that mean you have no trust in our very own KPLC?
Well,
Jeff just had to start the podcast.
People want to know.
Two issues. Of course, there has been power outages, but the reason we decided to switch to solar was because of some unfortunate incidents that happened in Murang'a. I think it's about 4 or 5 months ago. Yes, it is true. Often you'll find there are some arrears, money we owe Kenya Power. But the practice has been, when the county owes money to Kenya Power, if they decide to disconnect, they should not disconnect health facilities. They should target other county installations, but healthcare has always been deemed as something you can't touch because it's about human life. So there was some disconnection in some health facilities. Yes, of course, the county should pay its debts, we agree, but there are many reasons why at times we delay. Like, for instance, when there is exchequer delay in Nairobi. Like now, the last time we received county funds was in June 2024. July, August, and we are now in September, no money. And notwithstanding that, you have bills to pay, salaries to pay. So when Kenya Power decided to disconnect some medical facility, we thought that's quite unfair. So we decided as a county government that we shall transition our facilities away out of Kenya Power. And it appears it was something that was quite important, because I think somebody told me, I think Murang'a now is almost 90% off grid. I think Kireini, you are in Kireini, yes, right? I think they are now able to completely.
Even with the blackouts.
Yeah, even the blackouts,
yeah,
isn't it? Eh?
Yep. Yep.
Are there places where you have generators, or?
We do have generators, like in Murang'a level 5, but the point is, generators are, they emit carbon,
yeah,
and also is also expensive. So we believe this solarization program, which is currently targeting 73 medical facilities, will enable us to now ensure that we have power almost 100%, except when it's a little bit cloudy, I know.
By the way, did you lose any patients during that time of the switch off?
No, we didn't, but we felt that was quite unfair. But we want to thank the Kenya Power officials whom we talked to, and they were a little bit understanding, but we felt morally, I think we have to ensure our medical facilities have power 100%.
Can you give me their number? I'd like to use them in my house. They're always disconnecting me.
Roy, you talked about this 24-inch screen. How good are the cameras? Because Dr. Joseph will tell us, when you're examining certain things, you really have to get in close because the characteristics matter.
Yeah, so good question. The cameras are HD quality, so very good quality. It would allow you to do quite decent diagnostics. However, we have to know that telemedicine cannot do 100%. And our doctors are trained to know the limit. You have to know the limit, because it will reach a point where the patient, for instance, says, I have lower back pain. And there's a limit to what the doctor can do to test that. So what you do at that point, which is about 20 to 30% of the patients we see, we refer them to a physical facility. So you have to know, despite all the technology, we also have Bluetooth devices which connect directly to the electronic medical record system, meaning when a patient comes and they're triaged, for example, the temperature, pressure, and other statistics, they go straight to the system. It helps to reduce and make the diagnosis easier and better away from the screen, but there's a limit, and we train our doctors.
Joseph, is there always a danger of misdiagnosis?
Always. Always a danger of misdiagnosis. And this, I mean, it doesn't really matter if it's from a physical aspect or an online aspect, right? There's quite a scary number when you're looking at accuracy of doctors. And this is not to kind of throw anyone under the bus from a medical doctor perspective, but the global number of accuracy the first time you consult with a doctor in primary care is 65%. So that means that you have 1/3 of all diagnoses now. You're being misdiagnosed essentially 1/3 of the time, no matter if you're in Kenya or whatever country you're in. So coming to the fact and looking at telehealth and online health, well, how can this maybe improve misdiagnoses? Roy talked a little bit about the limitations, right? So again, like, where are the limits? And we making sure that when we reach that limit, we now refer you to some kind of physical examination and referral thereafter. The other aspect is also looking at how can you enable doctors to become more accurate. I mean, I went to med school. I know that 90% of what I learned, I've forgotten by now, probably, because there's a lot of diagnosis to keep track of. So what also His Excellency expressed is, now that we're gathering a lot of data, we can also apply that into the diagnostic process, knowing and seeing how accurate we are in the process and where we need to improve. So by the use of AI, we can also assist the doctors in the decision-making process. So it's almost like you're having an expert panel of sorts digitally, right? That you can constantly cross-check with, which ultimately should lead to an improved decision-making. In Bionate's platform, we're now at around 90% accuracy in primary care, and that's what we're continually building towards.
Steve Smith, bottom line, is this a game changer?
Most definitely. I checked with some of my doctors on the consultations last week, and what's really, really encouraging, one of the biggest challenges they're facing at the moment is the fact that when a patient does a telehealth consultation, the patient doesn't want to leave. They want to talk to the doctor. We've seen patients joining the queue again to come round again to, as they affectionately call it now, the TV doctor. So they're saying, you know, this is part of it. And I think when you think about game changer, we often talk about patients and their outcomes and their lives. But really, maybe what we should be thinking about is their livelihoods as well. People don't seek medical attention early enough. They don't have access to the doctors. You can do that. I've been in Kenya now for over 4 years, and the lives that are changed because they wait till the last minute, you know, to give their money instead of buying medicine, they'll use that money for something else, you know, looking after their families. Now they have the opportunity just to consult with a doctor. Don't leave it till the last minute. And that's as simple as just turning up at a dispensary, talking on the telemedicine, or even simply just using a phone call. So this is the game changer. This can change many things. Stop people going into poverty, affecting people's livelihoods.
Roy, bottom line, also, is this the future of medicine in Kenya?
It definitely is, not just Kenya, but Africa. The governor said the world is becoming more African. Population growth is crazy. By the 2040s, 1 in every 4 people born is going to be in Africa. Yeah. So the time is now for telemedicine to really change the landscape. And we feel that this is the right opportunity. We need brave people like His Excellency here to lead the line. And Steve has said something very important. 1 in 10 families in Kenya every year move into poverty. About 1 million people every year move into poverty in Kenya because of health. We are all in WhatsApp groups where people are trying to contribute. So we really need to change the narrative. And when it comes to preventive care, using AI, you think about what the governor said around taking the data to be able to do predictive analytics. So this is the time, and we need brave souls to really change the game.
Yeah. Good point. Governor, you get the last word.
So first is to thank my team in Murang'a, that is the nurses, the clinic officers, the top health management team, led by my CC, Dr. Mbogwa, also the 2 chief officers, Mr. Elliot and Mr. Isaac, and also Director of Medical Services, Dr. Mburu, and the head of nurse, Salome. I think they have done a fantastic job, isn't it? Also the young people in the IT. I think every day I'm told this machine has a problem, this machine has a problem, so they have to go around the entire county fixing those machines. I can only say thank you. Let me also say, members of the County Assembly of Murang'a, I can't really be able to say thank you. You guys, I think Murang'a people elected very progressive members of the County Assembly, because I've talked to them and I told them, let us just focus in development. And other leaders, including members of the members of Parliament, the Senator, our Senator Jonyoto, I can only say thank you. You have done a great job that we just focus in service delivery. I know it takes time to move our society a little bit ahead. We will not do much. We can only contribute. Others will take up once we are done with what we are doing. But I really implore and thank all Murang'a leaders and stakeholders that we have that single-minded focus in trying to make an effort. Healthcare is very complex. We are always receiving complaints in Murang'a. Hey, I don't know, I've gone to a hospital, I've lacked this. I don't know, I've gone to Murang'a hospital, there's this problem. So let me also say that we are not at any moment saying that we are now perfect in Murang'a. No way. I think it is a continuous progress that we require constant making effort to upgrade the healthcare system. The only thing we can say, we will make that attempt to the best of our knowledge. And I thank my partners for coming in that attempt to move Murang'a healthcare. And finally, as I have said, it's not just healthcare we have to look into. We have to think about youth unemployment. That's why we came up with a program like Murang'a Youth Service. About agriculture, that's why we have in Mkulima. About our infrastructure in Murang'a, that's why we have the program called Smart City that paves our urban roads. So all that effort might make Murang'a at least move 1 or 2 steps ahead. Thank you.
Governor, is there anybody you haven't thanked?
Giving an Oscar speech. I want to catch my salamu.
Governor Hirumu Kangata.
No, you see, when you watch a movie,
Yeah.
at the tail end,
The credit.
That's what
no, you have to, unless you're assuming you're the only guy.
Well done, Governor. Well done. Joseph, Steve, Roy, thank you so much. Appreciate it. A lot of people have learned a lot from this telemedicine. I'm sure you'll be getting more calls and more inquiries. Thanks so much for your help and input.
Thank you.
All right.
All right, so Roy Bore, CEO, HealthX Africa, CEO, COO, HealthX Africa, Stephen Smith. I have to call you doctor now. Dr. Joseph Murad, CEO, founder, co-founder, BuyInX, and let's go meet His Excellency. But that was Roy. Allow me to just call you Governor Hirumu Kangata, Governor Murang'a County.
Thank you so much for your inputs. And thank you for all your comments and questions. We appreciate that. We're going to take a break, come back. We got sports news and reactions on our magic wall. In the meantime, coming up.